Let's fix COVID-19 policy. The COVID-19 pandemic and subsequent government response has resulted in significant changes in the lives of Americans. In this podcast, we'll examine the problems posed by COVID-19 and provide you with background information essential to identifying possible solutions. Furthermore, this information will assist us in understanding how to evaluate potential solutions to the problem. We will then define specific objectives. These objectives will then help us to systematically evaluate potential solutions and ultimately identify the best solutions to the problem. Enough with the politics, enough with the censorship, enough with the deception. It's time for solutions.
Okay, Houston, we've had a problem here.
This is Houston. Say again, please.
Yes. Houston, we've had a problem.
Okay, it's time to fix our COVID-19 policy. Let's start with an examination of the problem. First, we need to recognize that this is a serious disease. People are indeed dying. One of the biggest issues beyond that, though, is the fact that the response to the pandemic has been one of fear. And it's been fear that's been driving a lot of the policy decisions, not data. Science itself has been politicized, businesses are closing, jobs are being lost, education's at risk, the rule of law is at risk, and our election integrity is at risk. That kind of defines the problem. Now let's go off and do a little bit more of a deep dive into information that might be useful in identifying potential solutions and evaluating those solutions. So we're going to look into the timeline, a profile of exactly what COVID-19 is, and do some deep dives into the data pertinent to the policy decisions around COVID-19 and the science that drive those policy decisions or are supposed to drive those policy decisions, and look at real issues around censorship and also examine what have been the specific government policies enacted in response to this pandemic. So from a timeline perspective, we're going to look at this from a United States perspective. And in the United States, the first case was identified on January 21st. President Trump restricted air travel on February 2nd and identified COVID-19 as a national emergency on March 13th. March 27th, Congress and the President got together and enacted the CARES Act to help with the economic recovery. And throughout the rest of the timeline here, there's been a back and forth between different messages coming out of the scientific community about what drugs work and what drugs don't work. We're going to examine that a little bit more closely later. So what exactly is COVID-19? Well, COVID-19 is one instance in a family of viruses known as coronaviruses. COVID-19 is known as a novel virus essentially because it hasn't been seen before. It's a new strain. Now, the way COVID-19 manifests itself in human subjects is through three basic mechanisms. Number one, hyperinflammation, known as a cytokine storm. Also blood clotting or increased blood clotting, and which can be very serious as well. And then low oxygen levels within the victim, which is tied to the other two mechanisms as well. All three of these are very serious conditions, and this is what led to death in many individuals as a result of COVID-19 infection. So here's the key data that we need to be following in regard that helps us gauge the severity of this particular outbreak. And the three pieces of data are the infection rate, the hospitalization rate, and the infection fatality rate. Now, a lot of people are hearing a lot of information around the number of cases and are they going up, are they going down? Well, I want to make sure everybody understands that case rate or the number of cases increasing does not equal the infection rate. And the main reason for that is a lot of asymptomatic individuals will not show up in the case rate because they're not getting tested. The infection rate is the sum total of all the population and who's actually infected with the disease and who's not. Infection rate is actually one of the key data points that can be manipulated through proper safeguards. Hospitalization rate is the next one. So once you've identified somebody's infected, they go into the hospital, and that's where they get treated with COVID-19. The reason this is so important is that our hospitals have limited resources. They have a limited number of beds, and they have a limited amount of key medical equipment like ventilators. So hospitalization rate, when we're talking about flattening the curve, what we're really trying to say is that we want to make sure that the demand associated with COVID-19 patients does not exceed our ability to supply hospital beds and key medical equipment. That's why we track the hospitalization rate. The next rate is a measure of how deadly is this disease. It's the infection fatality rate. This ties in with the infection rate in a very important way, in that if you've got a large portion of the population that's asymptomatic but does not test positive, or that has not been tested for the disease, but they still have it, well, you may find out that you have overinflated the fatality rate associated with disease. In other words, it's much less deadly than what would initially appear. As a matter of fact, initially, one of the big concerns around COVID-19 was that the fatality rate was communicated as over 3%. That's serious. That means 3 out of every 100 people would die if they contracted COVID-19. So as the infection rate goes up and the fatality rate, if the number of deaths stays constant or whatever, that infection fatality rate actually goes lower. So the more people you understand have the disease that don't die from it means that you have a lower fatality rate, which means that the disease in many respects is less severe than you might otherwise assume if you're just looking at the case fatality rate, and which is based simply on the number of cases. So it's important to look at these 3 data points: the infection rate, hospitalization rate, and infection fatality rate. Don't be deceived or don't be alarmed when you start seeing case fatality rates, which are something completely different. All right, so what exactly are the number of fatalities in the United States? Well, as of the time of this podcast, the number of deaths is being kept at around 156,000 people, which is very serious. But to put this in context, in 2017, which is the latest date that I could find for data on this particular topic, we had and related illnesses, which that data is not available for 2020 yet, because this is back to 2017. We had 129,898 people die of respiratory diseases, which are very similar to what's going on with COVID-19. We had over 48,000 deaths from influenza and pneumonia, which are very similar to this as well, and it totaled around 178,000 at that time for all of 2017. So just want to make sure we put this in context, and we don't know what the figures are for these particular other illnesses for respiratory disease and influenza and pneumonia in 2020. But if we find out that the numbers associated with COVID-19 plus the number of folks who've died of respiratory disease and influenza they lead to roughly the same totals in the number of deaths. It just means that some of the people that would normally potentially have died from influenza or pneumonia instead died of COVID-19. So we don't know what the true impact is essentially of COVID-19 on our system until we actually start tracking all the other causes of death in the same manner that we're tracking COVID-19. So let's look at who does COVID-19 most impact. And if you break it out by age, here's what we see, is that if most of the deaths that occur for COVID-19 occur in individuals that are 55 years or older. As a matter of fact, it's less than 7% are actually below the age of 55. So this is important when you start discussing what sort of activities can be supported going forward, who's most at risk, where are the vulnerable populations. It's clear in this case that the older you are much more vulnerable to fatality from this disease. And something else that's very important to go off and point out is that, as you might expect, 42% of these COVID deaths across the country occur in nursing homes. And so when we talk about vulnerable populations, that comes right up to the top of the list as a vulnerable population. I also want to point out, though, that when they actually track what the causes of death were from people with coronavirus, only 6% of those deaths have been identified with no comorbidities, which means that 94% of the people who have been book kept as dying of COVID-19 from COVID-19 actually had other illnesses that could have been catalysts for their death, not just COVID-19. So, in other words, it highlights that if you're healthier, if you're healthy, only 6% of the folks who were otherwise healthy actually died of COVID-19. In 94% of the cases, individuals were suffering from some other serious illness at the time of death while they were infected with COVID-19. So let's look by region, because this ties into different policies. In the United States, a lot of different states within the country took different approaches to government response to the outbreak. And in Michigan, which is where I live, we've had a total of 6,426 deaths, and we have a population roughly around 10 million, just a little under 10 million people. And so when you look at how effective has the government policies been in Michigan, you can look all over the world to go off and see what they've done in different areas in response to the COVID-19 outbreak. And one of the places that I think is important to look at, because they took a drastically different policy approach than Michigan, is that of Sweden. Now, Sweden actually has a little bit more people. They're a little over 10 million residents of Sweden. They've got big cities like Stockholm that are there's not a rural area by any stretch of the imagination, no more so than Michigan. But they've had less deaths than Michigan. And what's remarkable about this is the fact that Sweden actually kept their economy open. They did not take the lockdown approach or stay-at-home orders that were taken in Michigan, yet they actually had less deaths despite having more population. So if you want to go back and say, well, that's Sweden, they got a different lifestyle out there, a different culture, okay, fine. Let's go off and look at a different state here in the United States. Let's look at South Dakota. South Dakota kept its economy open, they kept their schools open, and what we saw in South Dakota was that they only had 130 deaths. Now, many of you may be saying, well, South Dakota does not have the same population as Michigan, and that's true. South Dakota has less than 1 million people living in it. So let's take a look at what are the deaths per capita. If you look at Michigan, the deaths per capita is about 0.06% of the population. In South Dakota, without their lockdown, without a stay-at-home order, it was 0.01% of the population. What's the current status and trends regarding the COVID outbreak? Well, what we're seeing right now, based on data from the COVID Tracking Project, is that the number of cases is still increasing and the number of deaths is still increasing. But let's take a look at something else that's come to light over the past few weeks and months, is that there are serious data fidelity issues associated with the information driving these reports that we are getting regarding the infection rate and the fatality rate. First of all, on the infection rates, we have we have examples of people taking multiple tests and insufficient bookkeeping standards to go off and ensure that just because one person takes 6 tests and tests positive for the disease 6 times does not mean that they that we have 6 new cases associated with it. It's got to be tied to the specific individual. The reason people would get tested multiple times is because they want to see when the virus has left their system so that they can go back to work and they're safe to get out in the world. Another big issue that we're seeing is the delay in test results. So these delays can be as much as 14 days and sometimes longer. So if you can imagine, you get tested and you won't find out for 14 days whether or not you're positive or not. That's a big issue. Also, a lot of the tests that are coming back with false positives. They're saying that you have the disease, but you don't really have it. And then something else that led to the CDC having its data tracking responsibilities moved over to the FDA is that it was determined that some were combining viral and antibody test results together, which is a no-no. They're supposed to be separate, and we'll get into the testing approaches in just a little bit. Another issue that we've had is that a lot of the hospitalization rates involve patients that are being treated as presumptive positive. So we've got people being admitted as having COVID, but they don't have any tests affirming that they are COVID. And this has happened with one of my family members as well. And so this is indeed happening. Another key issue is how do you measure capacity of a particular hospital? I mean, and when you highlight that a hospital is at over 90% capacity, well, hospitals are kind of designed, they're a business, so they're designed to be at over 90% capacity. The trick is whether or not you're able to go off and address and take care of all the people that are in need of critical care in that particular facility. You need to evaluate it against the capacity for the services that need to be rendered in that hospital. And then the other issue, and we kind of alluded to this already, is that of death rates and the issue of comorbidity. The idea that somebody may be admitted into the hospital with other illnesses, but they happen to test positive for COVID-19, they're then treated as a COVID-19 death. And there's also some perverse incentives that go along with hospitals rating somebody as a COVID-19 patient because there are financial incentives associated with that.
Reports are popping up all over the country that testing centers are over-reporting the true number of coronavirus cases. One America's Pearson Sharp has more as hospitals admit their data is flawed.
With the mainstream media sensationalizing coronavirus cases across the U.S., other reports are pouring in that hospitals are intentionally inflating their numbers of COVID-19 patients. An investigation of hospitals in Florida reveals health authorities were misreporting the number of positive patients all over the state. Hospitals were reporting a 100% positivity rate in infections, and numerous labs claimed every single patient that came in was testing positive for coronavirus. On Friday alone, 98 different labs reported 100% positivity rates, and experts say that's very concerning and means the results are likely inaccurate and cannot be trusted. One testing site, CentraCare, reported 83 people were tested and all 83 were positive for coronavirus, something health officials say is extremely unlikely. Yet when investigators contacted hospitals like Orlando Health, which was reporting a 98% positivity rate, the hospital admitted there were errors in their report. The actual positivity rate wasn't 98% as they had claimed, but just 9%. And at the Orlando Veterans Medical Center, 76% of patients were testing positive. But it turns out that was an error as well, and in reality, just 6% were positive. Most absurdly, last week, even a man killed in a motorcycle accident in Florida's Orange County was reported as dying from coronavirus. When questioned about it, health officials wouldn't reveal whether or not the man's death was removed from the overall coronavirus death count in the state. According to the Florida Department of Health, although labs are required to report negative results, many haven't been, and these are now being investigated. But Florida's not alone, and similar cases are popping up in other states as well. In Connecticut, a state lab found that 90 patients who tested positive for coronavirus last week actually didn't have the virus. The State Department of Health revealed there was a flaw in the testing leading to false positives. This is especially concerning since the testing method is from a widely used process the state adopted in June, meaning there are likely many other cases of virus-free patients testing positive. And in Rhode Island, another 113 patients without any coronavirus at all tested positive at a private lab based in New York. Health officials say the patients received false positive results and the testing method is being investigated. Based on these examples alone, it's clear that testing facilities and hospitals are likely significantly inflating coronavirus cases. That means despite the dramatic reports from the mainstream media, the true number of cases is likely much lower than what's being reported. Pearson Sharp, One America News.
All right, that talks about the data. Now let's look into the science that's supposed to be leveraging this data to make forecasts or to identify ways that we can go off and address the pandemic. First, we need to look at model-based forecasts, and I want to differentiate model-based forecasts versus actual trial-based forecasts. We're going to look at ventilators, which were talked about quite a bit at the beginning, but you haven't heard too much about them since, and there's reasons for that. We're going to look into hydroxychloroquine, which is probably one of the most politicized drugs in history, and we're going to go into that a little bit as well, and talk a little bit about asymptomatic transmission, lockdowns, face masks, large gatherings, small gatherings, testing methods, and we're going to talk about vaccines. So let's examine the science. First of all, when you talk about model-based forecasts, there was everybody was basing the initial response to COVID-19 on a model-based forecast at the Imperial College in the United Kingdom. And Mr. Ferguson, who provided this, predicted 2.2 million deaths as a result of the coronavirus. And that's just in the United States. What we've actually seen, and we've shown the figures on this already, is significantly less than 2.2 million. Matter of fact, less than an order of magnitude lower, over an order of magnitude lower, on the order of around 154,000 deaths, if the death toll actually is accurate. So let's look at ventilators. At the beginning, there was quite the kerfuffle around the availability of these ventilators because they had limited access to this at hospital facilities, and in the final stages of coronavirus, as you saw from some of the different mechanisms that affect the lungs, the way to keep a patient alive is by putting them on a forced ventilator so that they continue to breathe. So the idea of supplying enough ventilators at the beginning was very important, to the point where we even got automotive companies incentivized to go off and manufacture ventilators to fill the gap. But the fact of the matter is, no one ever was denied access to a ventilator, and we had a more than adequate supply. And also, one other key data point that nobody is talking about now, but needs to be talked about, is that 80% of the patients die after they were put on the ventilators, because by the time they were put on the ventilators, it was too late to do the treatment, which means if you do early treatment on this disease, you have a much better chance of survival. But once you get to the ventilator, your chances decrease significantly. Next, I want to turn to a discussion around hydroxychloroquine, or as it's abbreviated, HCQ. It's sad to say, but I think this has been one of the most politicized drugs in history. If you want to find out about how the drug actually works when it combats COVID-19, I encourage you to watch a 10-minute video out at Prager University. It's on hydroxychloroquine, how it treats COVID-19. You'll get a better understanding of the mechanisms that scientists believe are at play in the interaction between hydroxychloroquine and the COVID-19 virus, and how it actually helps protect the body from the virus. But I want to tap into an example of what I mean by why this is so politicized. And the next frame that I'm going to be showing you here is going to walk through a timeline of events. And what we're going to be doing is anything that you see that's an event in green is an event that gives hope. Keep in mind that it was in early March, I think it was March 13th, that President Trump declared a national emergency around COVID-19. People were desperate for looking for signs of hope. So every time you see something in green in this timeline, you will see a sign of hope. Every time you see something in red, it's something that diminishes that hope. So on March 17th, we had a French professor that identified a 100% cure rate with hydroxychloroquine. The president tweeted that out on March 21st. And when people claim that there was a short supply of this drug in the United States, when an Israeli company volunteered to donate treatments to the United States. It wasn't too long after that all the negative news started coming out about hydroxychloroquine. And I just want to encourage everybody to go off and do their own research. There's been some very promising studies around hydroxychloroquine. Go off and look at the data. And bottom line is there's a lot of data that suggests that it's been very beneficial in the treatment of COVID-19. But there are also a lot of people very concerned about the fact that this $30 treatment is something that may give people a little bit too much hope, and that's where the politics come in. All right, let's look at another topic here, the one that is the basis of a lot of government policies that are being put in place. And it's the topic of asymptomatic transmission, which means that can I, as somebody who does not have symptoms of COVID-19, I can still smell, I don't have a fever, I can breathe okay, no problem like that. Can I still transmit the disease to somebody else? And it's the fact, it's this kind of the fear of the unknown, if you will, that's the basis of the quarantine the healthy policies or the so-called lockdown or stay-at-home orders that are out there. It's also the basis of the mandatory face mask policies because you are told that if you wear a face mask, you cannot transmit the disease effectively. And but even if you don't have the symptoms, if you care about your fellow human beings, you're going to go off and wear that face mask because even if you don't have those symptoms, you could be transmitting it to somebody else. So we're all encouraged to wear masks, and because we don't know if we can transmit it, casually with anybody, even if you don't have the symptoms, we're all supposed to be staying at home as well. Well, you know what the science actually says is that asymptomatic people are 10 times less likely to actually transmit the virus. So a lot of these policies, is there some risk? Yeah, absolutely there is. But the truth is that the risk of transmitting the virus if you are asymptomatic is 10 times less than if you did display those symptoms. All right, so let's look at lockdowns. Are lockdowns a good policy to pursue? Well, a Japanese study that was done highlighted that the spread of the virus in closed environments is 18.7 times more likely than in open environments. And what we did indeed observe in New York hospitals was that 66% of the new COVID-19 cases in those hospitals were from people locked down in the same home. Lockdowns don't work. All the factors around transmission get exacerbated inside a closed, confined space. And actually, lockdowns, you can make the case that they do more harm than they do good. Matter of fact, the data shows this as well. If you actually look at the states that locked down their citizens versus those that kept things open, kept their businesses open, you'll see a much lower fatality rate in those states than you see in the states that decide to lock down their population. All right, let's look at face masks specifically. So we talked about in order to discourage asymptomatic transmission of the disease, everybody's being encouraged to wear face masks. And well, let's look at the science of face masks. Now, I'm going to break this down into two different camps. One is one camp is a set of analyses based on models, just like we were talking about with Neil Ferguson with the Imperial College model around the number of people that would die. They also have models for the transmission of the virus in the environment. And a lot of these models, and some of them were actually tests that were done as well that didn't necessarily test for transmission of the virus. What they would do is test or look at the transmission of particles in the air and with the assumption that would translate to transmission of the virus to somebody nearby. And so they created a lot of models that show the transmission of the disease when somebody would sneeze, when they breathe, and when they sing, whatever the case may be. They did models of all these different circumstances with different types of face covering, and they would show how particles were distributed in the air as a result of that. And the inference from all these different models would show that that virus was going to be all over the place, and it led to the basis of this 6-foot distance model, because a lot of the models that were shown showed that you could project, especially after sneezing, these virus-laden particles as far as 6 feet. Some studies have shown it out as far as 20 feet or whatever, but the bottom line is these models are the basis of a lot of the things we see around the social distancing guidelines. And so, just like with the model-based analysis associated with the fatality rates in that Imperial College model, what we've seen is that in the trial-based analyses, where they've actually studied people who've worn protective covering, had the face mask versus not having face masks on it, what they found is that it's inconclusive whether or not face masks actually protect you from the transmit, or protect others from the transmission of the virus because you're wearing PPE. Matter of fact, one of the best studies that I've seen out there comes to this very straightforward conclusion that says that there's insufficient evidence to provide a recommendation on the use of facial barriers without other measures. I mean, sure, there's other measures we could take. We could all go around walking around and living in a plastic bubble, but I don't think that's practical for anybody. Bottom line is, there is no conclusive evidence that face masks work or don't work. And so the idea that it's a basis of mandatory policies on the part of the government is something that should be put in question. All right, let's look at large gatherings. Now, the CDC guidelines around large gatherings is pretty clearly spelled out on their website. They've got some general guiding principles, just like we were talking about with people that are confined in lockdown situations. You're much more likely to communicate or transfer the disease, transmit the disease, if you are in a confined space and tightly grouped with a bunch of people in there. And so their guidelines at the CDC reflect this kind of thinking. It just kind of highlights what are the high-risk activities that we should go off and avoid. They even provide a checklist for those who are planning events that go off and say, here's all the different things you can do to go off and try to make your event as safe as possible. But put all this in context, though, the scientists at University of Washington went off and analyzed the different, what is the what is a crowd size that should be of concern or not? I mean, is it 250 people that's too much? Is it 100 people? Is it 50? The bottom line is nobody knows what exactly the right number is. The basic theme is the less is better, but one can socially distance in a large building just like they can socially distance in a small building. If it's the space in between individuals that really matters, then you can do that in a large building. It's not a function of the number of people in that particular crowd or not. Yet this is still the basis of where you've got caps on the number of people being gathered in any one place. That is still the basis of a lot of government policies in existence today. All right, let's delve into test methods. So let's continue this trek down into the science of COVID-19 and look at different test methods. And there's two basic categories for tests. One is a set of diagnostic tests. So that is, you got an individual, you're trying to figure out whether or not that person has the disease, so you can figure out whether or not you need to treat them with appropriate therapeutic protocols for COVID-19. The other category is that of prevalence. Essentially, it's testing for antibodies, if you will, which determines whether or not people have been exposed to the virus in the past, whether they've had it internally or they've developed immunity to it. And they're looking for antibodies that actually show evidence that that body's been fighting against that disease sometime in the past. So there are two basic forms of diagnostic tests. One is an antigen-based test, and essentially it's looking for certain proteins in the blood sample or then the tissue sample that's taken. Saliva sample. Typically it's a swab test up in the nose that you can go off and get a quick turnaround. Unfortunately, with that turnaround, you get a high error rate associated with it. As a matter of fact, sometimes you can get a high false negative rate on the order of 40 to 50%. In contrast to the antigen-based test, there's a PCR-based test, which is which essentially is a polymerase chain reaction test. This is the gold standard associated. What they're looking for are virus fragments in those tissue samples that they take. The tough part about this is that because you're looking for actual genetic evidence that the virus or strains or parts of that virus were in somebody's system on it, you could actually technically test positive from COVID-19, even in the gold standard of the RT-PCR test, if you ever had a cold, because some of those fragments, those virus fragments, are common to all cold viruses or all flu viruses, for example. So you have to be very specific as to what you're actually testing for, or you could demonstrate a false positive. So here are the three basic types of tests that are being taken: the antigen-based diagnostic test, the PCR-based diagnostic test, and then the antibody test, which is ideally suited to determine the prevalence of the infection in a particular community. And when we were talking about infection rates before, it's antibody tests that are used to go off and detect infection rates in a community. All right, so let's look at another controversial subject, and that is of vaccines. Bottom line is, right now, as of today, we do not have a proven, safe, and effective vaccine for COVID-19. A lot of people are using the presence or prevalence of a vaccine as a condition for reopening society. Bottom line is, we do not have one of those today. And I should also point out that on the CDC's own website, they highlight that for similar viruses, vaccines are only reducing the risk of contracting that virus by 40 to 60%. That's it. So even though vaccines are being held up as the end game for getting rid of some of the more onerous lockdown practices that are going on right now, even in the best of times, vaccines do not have an exceptional track record of protecting people. What they've also demonstrated that in some of the early trials associated with the vaccines, there are some very severe side effects, and also some concerns around folks because a lot of the testing methods that are being done right now have some ethical concerns associated with the source of the material used to go off and develop the cultures for these vaccines. Also, one of the leading vaccines that's being promoted right now is something called an RNA-based vaccine. And to date, there's never been an approved RNA-based vaccine. And now what we're seeing is that this new vaccine is actually getting the fast track. Instead of doing animal testing prior, it's actually being used directly on humans. And so this is a completely unproven technology. And we're now testing it on humans, and it'll be interesting to see how this unravels as time goes on. But the efficacy of vaccines is definitely something that should be called into question, and especially when you're talking about a 40 to 60% success rate for vaccines, as opposed to what's been demonstrated as an over 90% success rate for therapeutics such as hydroxychloroquine. Okay, which gets me to a key point. We kind of highlighted the good news, bad news that was going on in the media battles around hydroxychloroquine. Every time something hopeful came out, something bad would come out in the media to go off and try to diminish the excitement around it. And I submit that one of the key factors in that is that hydroxychloroquine for a full treatment on that is around $30. Some of the more expensive treatments that are being promoted and also vaccines, billions of dollars are going into the development of those vaccines. It's hard to believe that people would be too pleased with a $1 billion investment being taken away by a generic drug that costs $30 to treat somebody full cycle, that's been around for 65 years. You can understand why there's a little bit of pushback against hydroxychloroquine in that context. Matter of fact, and I highlighted too that physicians are actively being discouraged from prescribing hydroxychloroquine for their patients. Matter of fact, Ohio recently even precluded it from happening at they no longer allow pharmacies to prescribe it for treatment of COVID-19. There's other treatments that have been censored as well. So there are some nebulizer treatments that are featuring steroids that have been shown to be very effective at treating COVID-19. But as soon as that story was posted up in social media platforms, it was taken down off the platform. Matter of fact, on the hydroxychloroquine, just to talk about that one, there was a physician that was or a group of physicians actively promoting that in the Capitol recently. That story, talking about the importance of hydroxychloroquine and how effective it is, despite that it was being promoted by physicians on the front line who have actively used this to successfully treat patients. That video was taken down because it promoted the use of hydroxychloroquine. There's other physicians that are more holistic in nature that are promoting vitamin-based regimens, and a gentleman who I respect significantly out in the Detroit area by the name of Dr. Brownstein is one of those folks who's been told not to talk about his vitamin-based treatments for COVID-19. This amounts to censorship. So we're seeing anytime that there is something besides vaccines it's okay to talk about, but if you're talking about hydroxychloroquine, steroids, vitamins, or other therapeutic treatments or prophylactic treatments to address the COVID-19 pandemic, these stories are being censored. Vaccines, some of the details when they go into the track record of vaccines, anything that reflects negatively on vaccines and their origins or their purpose or anything like that, you're seeing that data systematically scrubbed from public space or public square. Anything that's critical of face masks, you're seeing similar pushback and censorship. Just to kind of highlight the extremes at which this censorship is happening, there was a Democratic state rep by the name of Karen Whitsett here, maybe 20 minutes away from my house in Michigan, that she had contracted COVID-19. And she was getting seriously ill as a result of the disease. She heard from President Trump that hydroxychloroquine was an avenue to go off and pursue. And her physician, her primary care physician, denied her that access, due in large part to all this censorship we're talking about upstream. But she was able to find a physician, actually a physician that was a gentleman I respect quite a bit. His name is Dr. Mohammed Arsawala. He prescribed hydroxychloroquine to Representative Whitsett. She recovered fully, and in response to recovering fully from COVID-19, she had the audacity as a Democrat to go off and thank President Trump for letting her know about this, because if it wasn't for him, she never would have found out about it. Well, you want to talk about censorship? She was essentially kicked out of the party as a result of this. There was a vote taken. She was kicked out of the party, and today I'm talking to you on the day of the primary, where she had a primary challenger deliberately put up against her in her seat, a strong Democratic seat here, because she had the audacity of saying something nice to President Trump in appreciation for identifying the effectiveness of hydroxychloroquine. There's a picture of Representative Whitsett with my good friend Dr. Dave Janda. This kind of censorship should not happen within a party, should not happen in America. If something is promising, everybody should know about it, and then it's up to the doctor and the patient to go off and to make a decision as to whether or not that particular treatment makes sense for them or not. All right, so let's take a look at what are the government policies that have been acted in response to COVID-19. And first thing I want to examine, we're going to get into this a little bit, is what is meant by the rule of law, because a lot of people are tossing that around. I want to make sure everybody understands it. Let's also look at stay-at-home orders, because those are the most prevalent policy that's been issued and most controversial across the country. A lot of them, a lot of government agencies are attempting to differentiate between essential and non-essential businesses and organizations. There's a lot of business regulations that have been put in place specifically as a result of COVID-19. There's threats to licensure. There's a program that most people don't even know about called Certificate of Need that we want to talk about because it deals with the flattening the curve discussion that we all started with on COVID-19. And then we're going to talk about the impact on schools and talk about public gatherings. And last, we're going to end up here on a discussion of nursing homes and some of our most vulnerable population. So first of all, let's take a little civics primer here. In America, our system of government is based upon the fact that all political power is inherent in we the people. You see it in the United States Constitution, the preamble, we the people. Okay, time for a brief civics review. All right, in America, all political power is inherent in we the people. You see it in the preamble of the Constitution. You see it in our Michigan Constitution, Article 1, Section 1, that all political power is inherent in the people. So that's the top echelon of source of political power. Now the people grant limited rights to the government or government representatives in something called the Constitution. Constitutional rights cannot be infringed upon by something called statute. Statute are the laws that get passed by those representatives that we have in our government. So the Constitution essentially grants limited power to our government representatives. Those government representatives use that power to pass what are known as statutes, or we commonly refer to them as laws. Another derivative of this is that sometimes within those statutes they allow executives to take certain course of action. Actually, it's the executive branch who has the authority to execute the laws. In order to do so, they will initiate something called executive orders. And a lot of governors around the country are being given authority under emergency powers to execute certain emergency or certain executive orders that leverage expanded powers under these states of emergency. One key point on this slide that I want to point out, though, is that no matter what the statute says, whatever latitude a statute passed by our elected representative says, that statute is always subordinate to the Constitution. So our constitutional rights are never infringed on the basis of any statute, and they're never infringed on the basis of any executive order that's issued. Constitution reigns supreme, and the rights guaranteed in that Constitution stay supreme. If a government entity would like to promote a course of action that is in direct violation to our rights in the Constitution, it is up for them to make the case for why people should do that, and under no circumstance should there be any penalty of law executed or placed upon as a burden to any citizen that does not comply with that edict. It's up to that elected representative to actually lead and make the case for that particular course of action. That's the way our system of government is supposed to work. We are not a banana republic. We are a constitutional republic. All right, let's look at those states where the freedom of assembly has been infringed upon. If you look at this map, you can see pretty much the eastern and western borders are all filled with governors who've used force of law to dictate stay-at-home orders. And right in the middle there, right up along the Mississippi River and out to South Dakota and North Dakota, we have folks that seem to respect that good old constitutional right to freedom of assembly. Let's start looking at policies that are developed around essential versus non-essential businesses. So essentially, a lot of governors have gone off and put out executive orders that specify which businesses are allowed to remain open, which ones are allowed to be closed or should be closed. And there's no scientific determination for any of this. And then each and every one of these governors who are declaring such policies has violated that fundamental principle enshrined in our Declaration of Independence that says that we are all created equal. And many constitutions across the country also specify specifically that our laws are meant for the equal benefit of all of us. So the idea of dividing us into an essential and non-essential camp is completely antithetical to the principle that we are all created equal. All right, and then there comes the endless business regulations. So, I mean, we'd actually have businesses that were open, but they were divided into products that could be sold at that business and products that could not be sold at that business. It got to the point where we've got grocery stores with masking tape on the ground denoting arrows that show where people can travel so that they don't cross too close to one another. And then you've got craziness like what you see here with the where the X marks a spot in front of the in front of these various kiosks. It turns out that there's very little rhyme or reason behind any of these regulations. There is no evidence of science behind any of these regulations, yet they are being done. And if businesses do not comply, they are threatened with the loss of their license. We're going to get into that in a little bit. Another one of the policies that are out there most recently is the idea of wearing face masks. A lot of these will require or provide exemptions for health reasons. And so if you are a business that is required to go off and use face masks, here's a recommended policy that you can put up out in front of your establishment. And that will keep you in line with the law. At least this is one that's been built here for the state of Michigan. I'm sure you can find something that's similar for your neck of the woods. Nobody can force you to wear a face mask, at least not lawfully. And you just need to be aware of what your rights are in that regard. And here's the big arm of government that has another way of going off and threatening the survival of business. If they don't charge you with outright violations of an executive order, what they can do is threaten your licensure. I already highlighted that certain physicians were being threatened with the loss of their license to practice medicine if they would prescribe hydroxychloroquine for patients that were suffering from COVID-19. Businesses are also threatened if they don't enforce face mask rules, if they don't enforce the X marks the spot social distancing rules, if they have too many clients that exceed the allowed gathering size or the allowed number of patrons in their establishment, they can get their license threatened. So a lot of businesses, rather than fight back on it and risk the loss of their license, will go off and willfully comply with the government. Now, something that a lot of people don't like to talk about, because we have a tough time believing that this actually exists here in America, but there's remember at the beginning of this whole coronavirus and whole COVID-19 pandemic concern, the big talk or the big buzzwords were flattening the curve. Everybody wanted to put forward policies that would flatten the curve. Well, the reason they had to flatten the curve is because we had limited capacity in our healthcare system to take care of seriously ill patients. And what people don't like to talk about is the fact that it's the government that puts artificial restrictions on this capacity. The government specifies via a policy called Certificate of Need the number of hospital beds that can be placed in a certain region. It specifies a constraint on the number of key pieces of medical equipment that need to be put in a particular region. It even affects nursing homes as well. And so where the term Certificate of Need comes from is that you actually have to petition a government agency or a government commission to give them permission to open up a business that would add to the number of hospital beds, for example, or add to the number of MRI machines in a particular area. So when we start talking about flattening the curve, please understand that one of the biggest reasons for the constraint that we have in our supply capacity that would force us to push for policies such as or responses such as that seek to flatten the curve. One of the biggest reasons we even have to do that is because of these onerous Certificate of Need laws that constrain the supply of these critical resources. ostensibly that is to inflate the price of those services so that the people benefiting from those services can get a higher price for it. But proponents of certificate of need say it drives out the need for unnecessary care. So anyway, which they say drives up overall healthcare costs. So there's a debate there, but the bottom line is, in a free market society, the idea of having to petition the government for the right to open a business is antithetical to the principles upon which this country was founded. All right, now we get to school. So we're coming up on fall right now. I'm talking to you right now in August of 2020. A lot of parents are considering where to send their their kids to school in the fall, or even if they can send their kids back to school. A lot of them have been schooling from home over the early onset of this crisis. And sadly, the vast majority of school systems across the country are going to be shut down or are currently shut down. And against this backdrop, got to remind everybody that the only 7% of those impacted by COVID who are subject to fatality from COVID are below the age of 55, and so everybody else is above that age. It affects the elderly in our society. So the idea of shutting down our schools, where we have the youngest among us, and also a lot of teachers in the education profession, by the time they get to 55, many are eligible for retirement as well. So, and many take advantage of that as well. So it begs the question, why is it, in context of the science, that schools would be shut down and closed? All right, now we get into the politics of public gatherings. So we talked about how group sizes, there is no exact science on what's a good group size or a bad group size, or the general thinking from a scientific perspective is that less is better. So the idea of getting together for public gatherings, whether it's for protest or otherwise, is seen as something that should be discouraged. Well, what we've noticed in the policies that are coming out from a lot of these governors is that those who participate in public gatherings that have a political ideology in contrast to their own, they are chastised and they are frowned upon and they are blamed for continuance of the outbreak. However, when these same individuals have a public gathering for a policy that they support, or for a protest cause that they support, you hear no such backlash against those gatherings. That tells me that there's a bit of a double standard into what are good gatherings and what are bad gatherings. Now, the science doesn't care whether or not you're supporting a Black Lives Matter protest or whether or not you're protesting the loss of constitutional rights. The science doesn't care either way. So it's either what's good for the goose is good for the gander. It should apply equally to everybody, and that's a key bedrock principle of our society, that our laws are meant to apply equally to everyone. So there's a lot of hypocrisy that's going on here in Michigan. Just weeks after Governor chastised that public gathering out in the Capitol, inside of our state capital of Lansing, where they were protesting her actions as governor, she decided and by the way, she chastised them heavily and said that they were going to be causing the spread of the virus. Here she is seen in not in social distancing context, but in participating in a Black Lives Matter protest out in the city of Detroit. Now, that's an example of, if it's a good cause, then you can go off and gather. If it's a bad cause, no, you're actually exacerbating the problem. We have the same thing with Dr. Anthony Fauci, who's one of the biggest proponents of face masks and social distancing. We have to get in a mode, especially among our leaders, where they practice what they preach. And then, of course, we've got the former president chastising people about the need for social distancing at a funeral where nobody is social distancing. Last, I want to look at one of the more concerning government policies that have been put out there. We already highlighted the fact that 93% of the deaths associated with COVID-19 occur in individuals 55 or older. So it is very concerning when you see governors like the governor of New York and the governor of Michigan have as part of their executive orders and part of their executive policy in response to COVID-19 to place the most vulnerable people in our society and provide incentives to go off and place COVID-19 patients with the most vulnerable population to COVID-19. It's concerning. And you have to ask the question, why would they do this? Especially when there were facilities available that could have treated these COVID-19 patients without putting them in proximity with these elderly residents of these nursing homes. In Michigan, we had something called the TCF facility that was stood up by federal agencies that had plenty of beds available for people if they were COVID-19 positive. You didn't have to put them in nursing homes. In New York, they had hospital ships that would come into the harbor that were nowhere near full capacity, that had plenty of room for COVID-19 patients, and they weren't fully utilized either. So it begs the question, why the policy to put COVID-19 patients into nursing homes? People need to answer that. All right, so that's a lot of information in the background. Apologize that it took so long. A lot of time went into researching all this topic, but in the footnotes of this podcast, I'm going to make sure that you have links to all the different sources of information so you can go off and verify it yourself. Now we're going to get into a very important part of this fixing stuff here, of the solution methodology we're working on, and that is establishing objectives. And the idea of making these objectives transparent so that everybody sees them is very important, because then we're going to go off and evaluate all the potential solutions to this problem, this COVID-19 problem, based upon these objectives. So it's important to be very clear about what they are. All right, so what are some reasonable objectives for resolving the issues around COVID-19? First of all, I think everybody would agree that a primary objective would be that of minimizing fatalities. We want to protect the sanctity of life and minimize the likelihood that somebody would die as a result of COVID-19. I think in the wake of all the fear-mongering that's done, and I think people would welcome the idea of driving the decisions that are made regarding policies via the data, via the science. Another key important thing is that we need to restore the rule of law. We can't afford to allow governors, legislators, judges, and even citizens disrespect the order of law. And our society is based upon that rule of law. Once we lose that rule of law, we lose our structure as a society. And I believe there are some people that would like to see that happen. There are people that are seeking the fundamental transformation of our society, but for the most of us, I think we'd agree that the idea of restoring the rule of law is a very important consideration, or a very important objective of our COVID-19 policy. Something else that's very important is that of restoring our economy, especially when you look at when America's economy suffers, people all around the world suffer. There's a recent study that highlighted that 10,000 children a day all across the world suffer when the United States is an economy that has a downturn based on this COVID-19. When we shut down our economy, all the resource that would otherwise go to assist others disappears as well. So it's important that we go off and restore our economy. We also need to resume education. We can't afford to have gaps in the education of our students, our next generation of leaders. And what's evident throughout all this is that we need to restore an appreciation for scientific integrity. And a lot of us are seeking to restore the idea of returning to normal life. They're not interested in any fundamental transformation of our lives. They seek to restore the lives we had before COVID-19. So all these objectives are out there, and I think it's safe to say that not all these objectives are created equal. Some are a little bit more important than others. For example, I would submit that minimizing fatalities is of very high importance. The idea of driving decisions via data is also something I would say is extremely important as well. We have to get out of this fear-based policy setting that we seem to be trapped in. And the idea of rule of law is extremely important as well. After all, we have a lot of people who served our country in uniform that died for the sake of our Constitution and our system of government and our rule of law. We need to respect those sacrifices. We also need to recognize that we need an economy that's burgeoning again, that's working on all cylinders. A lot of people invested a lot of their life to build up a business or to build up a trade, to build up a skill, and we need to provide a means for them to be able to take care of their family and also in turn help others out as well. We need to get back educating our next generation of leaders, and I'm only rating these next two objectives low, not because I don't think they're important. I mean, I put them up there as objectives in the first place, but because relative to the other objectives, they're relatively low compared to it. So I think people would graciously give up a return to normal life if it meant that they could save more of their fellow citizens. So that's the summary of all the objectives we'd use to go off and evaluate the different solutions. Now we're going to get into, well, what are some different solutions? And I'm breaking them up into four basic groupings, if you will. One set of solutions pertains to personal behavior. What can I as an individual go off and do? The next is targeted at healthcare professionals. What can people in the healthcare field do to address the COVID-19 solution, the COVID-19? Then we break it into science. So scientists and scientific research, what can we do specific to science to address COVID-19? And then last but not least, what can government authorities do in response to COVID-19? Now, I'm going to be listing a lot of solutions that are out there, and I think it's important that I don't limit those solutions just as the solutions that I like. I want to go off and evaluate all these solutions objectively and against the objectives that we established in context of all the data that we shared when we were sharing all that background information. So if you see solutions that are up here that you may not agree with, that's fine. I may not agree with them either, but we got to have them up there so we can have a good, rational, data-driven approach to finding what the best solution is. And if you don't see a solution that you think should be addressed in here, well, you'll notice that on every one of these solution podcasts, there's a build number. This one happens to be build 1.0. If you see some other solutions that should be addressed, please let me know. We can always go to build 1.1 or build 2.0. Just let us know. There's ways to go off and share comments on these presentations, and we'd love to be able to have an opportunity to consider additional options. So without further ado, let's look into what are our solution options regarding personal behavior. All right, when we look at personal behavior, number one, everybody agrees, same things your mom and dad used to tell you when you were a kid still apply today. Good hygiene. Wash your hands, wash your face. When you sneeze, cover your mouth. When you cough, cover your mouth. Also, because of all the comorbidities that are out there and patients that have fallen with COVID-19 in their bloodstream, the idea of being in good physical shape is very important. So the idea of being in good physical health is extremely important. And just like before, if you've got the flu, you stay home. You don't go to work and spread it to everybody else. Same thing with COVID-19. If you find that you are symptomatic, then stay home. Don't spread it with anybody else. One of the other solutions that are out there that are being proposed is that of wearing face masks. Let's go off and evaluate that where it fits into the big picture. We can also limit the size of public gatherings. Remember, we don't know exactly what the right number is on this, but we do know that less is best. So what is the idea of we got to consider limiting the size of public gatherings as one of the possible solutions. And then the other part is avoid high-risk behaviors. So the idea of getting in these close gatherings and being in close proximity with somebody with a COVID-19 is something that should be concerning, and also protect those that are in that susceptible category. So if 93% of our deaths are found in people 55 or older, pay particular attention to good personal behavior and habits around people with that fit that demographic. All right, so now What can we do in the area of science? What are some solutions we can pursue there? Number one, improve test data. That involves everything from standardizing the data around something that actually works, so that we're comparing apples and apples instead of apples and oranges every time we pull together test data. That would be very important. Also, we need to improve the accuracy. We already talked about the fact that antigen tests, some of them will have a 40 to 50% false negative test rate. Even some of the PCR tests that are out there can have a significant false positive rate as well. And you can imagine that anybody, if the test is so sensitive that if you've ever had a cold, you're going to have the antibody, or you're going to have the evidence of that genetic material from that cold virus in your system. Well, that can give a lot of false positives, and we need to improve that accuracy and make it targeted at COVID-19. The other thing is, once we get that data, don't hide it. Make sure everybody has access to it. Those 3 data points we were talking about, infection rate, the hospitalization rate, and the infection fatality rate, those 3 data points should be tracked by every government, every state government, and the federal government across the board, so we can get a very good picture of how well we're doing, and that the policy should fall in line with those trend lines. The other thing we need to do in science is improve that peer review process. One thing we didn't talk about in here, but it's in the footnotes, is that early on in the discussion of hydroxychloroquine, there was a study put out by Lancet, which is a very prestigious medical journal, that highlighted that hydroxychloroquine led to more deaths, not less. When people started questioning the data associated with that study, they found out that the data was suspect, and Lancet actually had to retract that assertion around or their claims around the harmful effects of hydroxychloroquine. So obviously there was a gap, there was some problem there in the peer review process. That needs to be fixed, and needs to be expedited too. When we're at times of national crisis, we can't wait for a year and a half. There's got to be a way to go off and evaluate these studies in a much more time-expedient manner and an accurate manner. The other thing that's important is that promote herd immunity. If you want to stop the infectious spread of the disease, well, one way is to make sure it's trying to jump onto people that are immune to it, so that they will not shed it to other people. The other thing that a lot of people don't talk about, but one of the reasons I want to talk about hydroxychloroquine, and I want to talk about remdesivir, and I want to talk about nebulizer steroids, and also just even vitamin therapy, is that there are ways that you can prevent or that you can treat people that have contracted COVID-19. There's also ways to go off and prophylactically prevent COVID-19 as well. And hydroxychloroquine, as mentioned before, has been around for 65 years in practice. It's a relatively inexpensive drug. It's something that has been taken as an anti-malarial regimen. It's also been taken for treatment for Lyme disease. When our troops went over to Vietnam, a lot of them, or most of them, were given hydroxychloroquine tablets to go off and help prevent malaria. This is something that has been safe for many years. Its efficacy is something that is the only thing that's been brought into question, and there's plenty of anecdotal evidence that suggests it is very, very effective. And so why wouldn't we go off and promote such treatments? There's a lot of folks that are in the camp that says, no, forget about the therapeutic treatments. Let's focus in on the vaccines. We're never going to be safe until we see the vaccines. I've already shown the data associated with that. Even the CDC says that 40 to 50% of the time the vaccines are only good at reducing infections 40 to 50% of the time. So you got to put that in context of the effectiveness. It's not a cure-all for anything. Also, one other thing that's very important, I think it's important to promote trial-based studies over model-based studies. Model-based studies, I mean, you can put in a simulation anything you want. Until you actually see it in the real world, it's not actually proven. A lot of the discrepancies that we're seeing between the dire predictions around COVID-19, what we've actually seen, are due to model-based studies versus what we're seeing in the real world. For science is observational at its heart. You need to observe something to be able to validate something as a model. So all these models that are out there, it's okay to have models. I've done a lot of finite element analysis in my career as an engineer, but those models were always validated with tests. And so we need to do the same thing when it comes to models in science. And ultimately, you need to have the data that's out there to validate any model that you have. And you got to see it, experience it in the real world before you can have any confidence in what any model may say. All right, let's look at what we can do in the healthcare. So here's some solutions in the healthcare space. Number one, improve testing and related patient management practices. I don't know how many of you have seen the video from the nurse that decided to go undercover at, I think it's Elmsworth Hospital in New York. And she was highlighting the flawed testing and patient management practices where patients which had tested positive with COVID-19 had been put into rooms with patients that are not have not tested positive with COVID-19, or whose test results are not back yet. So they may be negative and have been put into a risk, put at risk by putting them with a COVID-19 positive patient. So hospitals in particular need to improve their practices around testing and patient management practices. Also, one of the options is to restrict elective procedures so that you free more room for an intensive care of COVID-19 patients. So that is an option. It's also one of the other solutions to promote prophylactic treatments. We discussed that a little bit under science. And then also, we should allow physicians to treat symptoms early. And a lot of the push early on for more ventilators was focused on kind of the end of the care protocol for people suffering from COVID-19. We need to move that focus up through the promotion of some of those therapeutic treatments early on. And what we've seen time after time again, and what a lot of the early anecdotal studies said, was the earlier we treat patients with these therapeutic cocktails that are out there, the better their chances of surviving COVID-19. So we need to provide physicians with the ability to go off and do that. There's a lot of hospitals that will still ban the prescription of hydroxychloroquine, for example, to their patients, and we need to discourage such behaviors. And then the next thing is to prepare for the next crisis. In addition to the shortage of ventilators, there is a shortage of PPE or personal protection equipment. There's a shortage of tests. There is a shortage of reagents for the tests. There is a shortage of a lot of different equipment that we should take heed from this, from the response to this pandemic, and prepare ourselves for the next time that something like this occurs, because we need to learn from what we've done in this previous, in this current crisis. All right, so let's look at various government solutions, a whole bunch of them here, so please stay with me on it. One is you can issue a stay-at-home order. The other is you can start mandating face masks. You can go off and mandate or require contact tracing, so you can actually identify where the disease is spreading. Now there is mandatory vaccination, so you can require that as a condition of getting back to normal. You can respect constitutional rights and the rule of law. How about that for a change? Also, maybe one of the government policies we should pursue is that of protecting vulnerable populations. Maybe we should promote data transparency and discourage censorship. That would be very important. How about restricting which businesses can remain open? Well, that's one policy you can go off and pursue. Is that something we should be pursuing? Well, we're listed in the options. Closing schools, another option for the people that believe that we shouldn't have any gathering independent of whatever the demographic is. Closing schools might be one course of action pursued. If that happens, I would submit that parents should have the option of where they should send their kid. So if your school has chosen to close themselves down, or if the governor has ordered all the public schools in your area to shut down, then maybe parents should be given a choice whether or not to send their education funding to go to a private school so that their kid can still get educated. Another option is to go off and safeguard drugs or prevent what some people believe is, or for what administrators believe is a non-acceptable prescription authorities, that they'll restrict prescriptions, like what happened here in Michigan, where the governor threatened the license of any physician that prescribed hydroxychloroquine for COVID-19 patients. Another option to pursue, kind of on the opposite end of that spectrum, is to remove prescription restrictions for safe drugs. Another option that should be pursued, if you're really worried about flattening the curve because you don't have adequate capacity, should re-examine whether or not you need certificate of need laws at all. Maybe we should pursue those. And last, I'm going to go off and put this out here for that our elected representatives, when you see a government official that is not acting in accordance with the rule of law, you have the duty and the right to go off and pursue impeachment. And for the citizens, there's another option in most states called recall, but legislators have the option to go off and impeach government officials that refuse to follow the law. So in a nutshell, these are some of the government-based solutions that I believe we should go off and consider. Now the trick is, how do you find the best solution out of all these different options that have been put together? So we got 4 different groups of solutions with a whole bunch of different ones that are out there. The trick now is to identify what is the best solution. And this involves going off and rating each one of those solutions against the objectives. And when you do that, you come up with a nice little eye chart that you see here. And I'm going to save you all the details into this. If you're interested in the details on this, this PowerPoint presentation is available for people that have joined the Right Stuff membership club. And the spreadsheet that was used to calculate all this is also available there. But here's what we got. The number one government policy, the number one solution that should be promoted right now is that of protecting vulnerable populations. There's no reason we should be putting COVID-19 patients into nursing homes. And the least effective policy, according to our objectives, would be that of stay-at-home orders. I would submit that if you actually weight every single, or you actually score the principle of a stay-at-home order against every single one of those objectives, it does not score very well. So this is kind of the summary. Now I'm going to go into let's go into a little bit more detail, if you will. The top three solutions overall for COVID-19 policy are: number 1, protect vulnerable populations; number 2, remove prescription restrictions for safe drugs; and number 3, allow physicians to treat symptoms early. These are 3 basic things that should be allowed overall and promoted up front. Now, if you look into each one of those particular categories, because they're divided up into different groups, and what can you do as an individual? The top 3 things you can do as an individual is: number 1, if you're sick, stay home, self-quarantine. Do your best to get in good physical shape so that you're not as high a risk of dying from COVID-19. And number 3, or frankly from any other disease, the other thing is good hygiene. Wash your hands, cover your mouth when you sneeze, that kind of stuff. All right, in the scientific community, what can they do? Number 1, promote herd immunity. That means the infection does spread, but the idea is that eventually you're going to go off and prevent the spread any further and prevent the contraction, because everybody is immune and it has no way of getting transferred from patient to patient. The whole concept of herd immunity, I might point out, is that asymptomatic transmission is very low, and it recognizes that with the principle of herd immunity. The next thing in science is that of promoting therapeutic treatment, and then also develop vaccines is something that should also be considered. And from healthcare perspective, in the healthcare sector, we should be allowing physicians to treat symptoms early. We should be promoting prophylactic treatment, and we should improve testing and related patient management practices. And from a governance perspective, once again, top priority is protect vulnerable populations. Number 2, get out of, you're not doctors, so don't pretend that you are one. Remove prescription restrictions for safe drugs. And last but not least, restore respect for our Constitution and the rule of law. That means if you've got a case to be made that is a deviation from what the rule of law and what your current powers are telling you, make the case as a leader then, without the rule of law, force the law behind you. Say that, hey, we really think this behavior is what we need to go off and pursue. I don't have the authority to tell you to do that. All I can do is ask. And then what that does is forces those in authority to make their case, which is kind of the point of this whole approach to COVID-19 policy solutions, is make your case, get systematic, put together a rational, data-driven approach to solving the very real issue of COVID-19. When we do that, I think we're going to find out that we're much better off. And so I want to thank you for your patience sitting through this engineer version of COVID-19 policy solutions. If you're looking for a shorter version, we do have a media version that just goes right to the chase on each one of these topics. But I want you to understand that each of these points that were made in this presentation here is backed up by footnotes, backed up by data, and I think that's the way we should approach all complex problems that we have, and simple problems for that matter, that we have in our society. It's time to get away from the fear-mongering, get away from the demagoguery, and start taking a more rational, systematic approach to problem solving. When we do, we're going to find out that our society is a heck of a lot better than it was before. Thank you for your patience.